Hi, and welcome to another episode of the Cancer Now What vodcast, brought to you by Arizona Center for Cancer Care. My name is Jenny, and I'm so glad to be here today talking with three physicians in our community around pain management and cancer care. We have Dr. Ruchir Gupta with Mountain View Headache and Spine. We have Dr. Rishi Agarwal, Medical Oncologist with Arizona Center for Cancer Care and Virginia G. Piper Cancer Care Network, and Dr. Cory Heal, Radiation Oncologist with Arizona Center for Cancer Care. Thank you all so much for being here today.
Thank you.
Really appreciate it.
Thank you.
So let's kind of set the stage here, if you will, in this conversation, right? Because people have pain all the time, and it's not just cancer patients who have pain. But for the purpose of this conversation in our audience, we really want to figure out how pain management fits into a cancer patient's journey. So I'm going to start over here with the oncology side of the table, if you will. Dr. Agarwal, Medical Oncology, what type of pain is involved with cancer and cancer treatment from a medical oncology perspective?
So pain is actually one of the most common symptoms that cancer patients have. The pain could be due to the cancer itself. It could be due to the procedures involving in cancer diagnosis or treatment, or it could be directly related to the treatment. For example, if a patient has a mass on the spine, they can have pain from the spine, metastatic disease to the spine. They can have pain related to the fracture from the cancer in the spine. And then, if they get a biopsy of that tumor, sometimes they will have pain related to the procedure. And then if they get cancer treatment, there are side effects from cancer treatment which can cause you to have pain related to cancer treatment. So pain related to cancer could be because of multiple causes. Also, you can divide cancer pain into acute pain or chronic pain. So pain which is more acute, for example, due to a fracture or something like that, which is quick to come and is reversible. Then there is chronic pain, which is a long-standing pain. So a lot of patients, in the range of 70-75% of cancer patients, they present with some sort of pain related to cancer.
That's really unfortunate.
It's unfortunate. Yeah.
So when you are seeing people in radiation oncology, I know sometimes you're actually treating the pain with radiation treatment. But what are some of the reasons that people who are getting radiation oncology will experience pain during their cancer treatment?
Sure. So pain from cancer has a lot to do with where it is. So someone with a head and neck cancer might have pain in their mouth or when they swallow. And then when I'm giving radiation to someone for a treatment, oftentimes the pain associated with treatment also is related to where we're treating them. So if we're treating cancer, sometimes not only are we damaging the cancer cells, but some of the nearby cells around it also gets damaged and has to repair. And so people can have pain associated with the cancer treatment itself.
Okay. Yeah, it's definitely got to be tough on you guys to see your patients in pain when the whole goal is to cure them of their cancer and give them quality of life. So it's got to be very tough for you when you've got patients in those situations. What do you do when a patient is saying that they have pain? The first thing that you do, identify what it's from, or how do you navigate that?
So if someone comes into me and they're having pain from a cancer, the first thing I'm going to do is examine them and evaluate kind of where that pain is and what it might be coming from. I'll look at their scans and see if there's anything that can kind of correlate with where their pain is. And like was said earlier, if it's a lesion in a bone, that's something I can treat, then I'm gonna try and address that pain. If I'm treating them and they start to have pain during treatment, at least for radiation, when someone's undergoing radiation treatments, we see them at least once a week during their treatment. And the whole purpose of that is to try and identify early on if someone's having symptoms so that we can address them early. So sometimes, if it's really bad, it's getting them involved with a pain specialist so that we can address that. Sometimes we can re-image them and see, hey, is this tumor growing or something? Do we need to adjust our treatment? And oftentimes there's a lot of interventions we can do during treatment to try and help them. So for breast cancer patients that are getting a sunburn, we'll prescribe lots of creams and topical steroids to try and help. If it's someone that we're treating their head and neck cancer and their throat is sore, they're having pain in their neck, there are different elixirs we can use to try and help, or giving them pain medicines. So a lot of it depends on where their tumor is, but during their treatment, we have time built in to try and diagnose and intervene early so that people can get through treatment, because that's what they're going through all of this for.
For sure. So then from a medical oncology perspective, Dr. Agarwal, is the pain different from chemo than it is from radiation? Does it present differently, and do you manage it differently than in radiation oncology?
So, yeah, the pain that presents secondary to cancer treatment will present differently from the pain that presents with the cancer patient. Most of the patients who will have treatment-related pain, in my experience, it mostly develops gradually, and most common pain that we see with the treatment is neuropathy that we have for a lot of our chemotherapy drugs. Unfortunately, have a side effect of neuropathy, which is an unfortunate side effect because a lot of these drugs are also very active in treating cancer. So on one hand, we are treating the cancer, but that also causes an unwanted side effect of neuropathy. Besides neuropathy, sores in the mouth is another side effect that we see from a lot of our cancer treatment drugs. And that is also a very stressful situation for the patients because they have sores in the mouth, they cannot eat, it's hard to swallow. So, and then one thing leads to the other. If you're not eating and drinking well, you get dehydrated, which leads to increased side effects from the chemo. So managing pain in such situations is very, very important. And we take pain related to cancer very seriously, and we are very prompt in identifying and treating the pain related to treatment or from the cancer.
So that's a big piece of the training for you guys when you're learning how to take care of cancer patients, is how to manage their pain from an oncology perspective. It's part of the process for sure. But sometimes you have to call in the pain management specialist. So, Dr. Gupta, tell us a little bit about your specialty, how you got involved in helping cancer patients with pain management, and a little bit about your background.
Sure. Thank you for inviting me to be here. It's really a pleasure. My own background is that I am an anesthesiologist, but I was a practicing anesthesiologist for 10 years, and I decided that I wanted to pursue a fellowship in chronic pain management. So I went back for a fellowship, and when I approached pain management, I wanted to approach it not from the traditional way of injection therapy. I think injection therapy is very important and has a role to play. But there is a role that has not yet been fully established for infusion therapy. And I think specifically IV ketamine infusions are very effective for a lot of the types of pain that Dr. Heal and Dr. Agarwal were referring to. Ketamine is an anesthetic drug that we've used in clinical anesthesia for over 50 years. In the last 20 years, research has been done that has shown that if given in low doses over the course of an hour or sometimes several hours, it can be very effective for chronic pain. When you think of chronic pain, we're talking about fibromyalgia, central sensitization. Even cancer pain falls into this category because cancer pain is often so severe that nothing short of strong opioids will touch it. And the problem with strong opioids is really the side effects that, okay, you could either be awake and in pain or asleep and presumably not in pain. But one can also argue that if somebody's asleep, that doesn't necessarily mean they're not in pain. They may just not be able to verbalize it. So you're not really taking away the pain in that situation. So ketamine is a good adjunct that can reduce doses of morphine and other opioids. Research has shown that in some cases it can reduce it up to 50%.
So is there less of an addiction risk with ketamine? Because I know that that's a huge flag when it comes to opioids.
So ketamine is not an addictive substance.
Okay.
You cannot get hooked on ketamine. I think ketamine has gotten a negative rep going back to the 1980s, the whole drug epidemic, Special K. But what a lot of people don't realize is that ketamine was not abused by itself. It was abused with amphetamines and other medication, any other drugs that are addictive. By itself, ketamine is not going to lead to addiction.
But it can help with this kind of pain that they're talking about.
Absolutely. And when you give it as an infusion, in an infusion center, in a pain management center like mine, you're monitoring the vital signs the entire time. So it's actually very, very safe. Because unlike a pill, which you take at home, nobody's monitoring your vital signs at that point. You're hoping that it's fine. You're not overdosing. But with ketamine, you're only getting it in a controlled setting. So there's no chance of an overdose in that situation.
So how did you, moving from anesthesiology into pain management, really decide that this was a way that you wanted to treat cancer patients specifically?
Well, because, when you think of cancer pain, I think we as a specialty have not done enough to address it. I know that even in my training, when we had patients that presented to us that were on high doses of opioids and had cancer, we would say, okay, well, we can tweak your opioids, but beyond that, we don't have much else to say. So I think that ketamine is filling a major void in our practice, so that when these patients come to us, we have something else to offer, as opposed to just, okay, well, we'll do a simple injection in your shoulder for shoulder pain with steroids versus we'll put you on an opioid. There's a third option. This option goes everywhere in your body because it's an infusion into your vein. So it can treat leg pain and back pain and neck pain and nerve pain and bone pain. It can treat pain from all causes. And while no pain remedy is 100% across the board, in the right patient, it can serve a very strong purpose.
So if one of the oncology physicians refers a patient to you for this, they come to your center,
Yes.
right? And how long does the infusion take?
From the minute that the patient arrives to the minute they leave, we block out 2 hours. The actual infusion will be a little over an hour.
Okay.
Because the amount of time to get an IV going, have them sit down, possibly during the infusion, they may have to use the bathrooms, you have to halt the infusion, then recovery time so that they feel, back to their normal self. All of that, we think within 2 hours can safely be done. So it's like a 2-hour commitment.
And how often do they have to come back for it?
So that's a great question. We've done majority of our ketamine infusions on patients with fibromyalgia, central sensitization. These are, conditions in which they have a certain level of pain that they live with. For those patients, I have a protocol where we have them come in every day for 5 days, and they receive their infusion. And then after that, we do a follow-up visit, and then we decide, do we need to do more infusions, or do we do maybe a booster infusion at the 3-week or one month mark? Cancer is different because cancer is dynamic, right? It's growing, it's changing. Treatments are happening to shrink cancer. Those treatments can be causing pain. So it's much more patient specific. What I would say is that we would start with 5. We would then do a follow-up visit. At the follow-up visit, we'd see where the pain is. Do we need to do another 5? Maybe we can do 3 this time. After that, we see how long that lasts. We see what else is being done, maybe by your radiation oncologist. What else is where is your cancer right now? Is it increasing in size, or is there a surgery that you have scheduled to do some debulking? So all of that plays a role in the cancer treatment that we offer. But the nice thing is that our clinic is one of the few clinics, I believe it's the only clinic in Arizona that has insurance coverage for IV ketamine. So as we go through this journey, this is not something that the patient has to worry will eat into their bottom line or their savings. This is something that we're getting covered by insurance. In most cases, obviously everybody's a little bit different. In most cases, we are getting it covered by insurance. And this gives us a lot of flexibility in really customizing the care for the patient.
And has there been data surrounding this and telling us that it works, and that, obviously insurance usually doesn't cover it unless there's data saying that it's helpful. What have the studies shown? So
there's been studies that have shown, a meta-analysis showed that it can reduce, ketamine can reduce morphine requirements by up to 50%. But again, the data is not just looking at ketamine infusions. It also looks at ketamine that was given intrathecally, or ketamine that may have been given as a nasal spray. So right now, we're just scratching the surface with strong evidence with ketamine infusion data. But it is very highly respected in the treatment of complex regional pain syndrome. It is very highly respected for fibromyalgia. With cancer pain, we are seeing that it's reducing morphine equivalents, and that's what I say to everybody, that ketamine is not some magic wand that's going to take away your pain. But if we can reduce your opioid consumption, we decrease the side effects, we decrease the dependency, and we create a space to go up on the opioids if we need to.
Got it. That makes sense.
So again, it's something that will be part of the picture.
What does intrathecally mean?
I'm sorry, intrathecally means through the spinal cord.
Thank you, that's helpful.
Yeah,
okay.
yeah.
And can you please, Dr. Agarwal, tell our audience what exactly is neuropathy?
So neuropathy is when your nerves get damaged from chemotherapy, or actually some of the cancers they have direct neurotoxic manifestations. So whenever you have a nerve damage, you can have some people will have pain sensation, some will have numbness or pins and needle sensation. So that's usually what we
Mostly
call
in the
neuropathy.
limbs then is when they get that, or?
It's mostly in the limbs, lower extremities or upper extremities, in your fingers or your toes. Sometimes it presents with loss of balance. I have patients who find it hard to drive after developing neuropathy. So,
Okay. And is neuropathy something that can be treated with the
Oh,
ketamine infusion?
Absolutely.
Okay.
It would be very, very helpful with neuropathic pain. Also, recently the FDA approved spinal cord stimulators for neuropathic pain. And that is, again, a conversation that I would have with the entire team, that would a spinal cord stimulator implant be a possibility for this patient. But the nice thing about spinal cord stimulators are that they're these, for lack of a better term, wires that you put into the epidural space that send electric signals to the brain that block off the pain signals. And so
cool.
it's a drug-free modality. And so again, when we think of cancer pain, my clinic doesn't just, well, I'm not the ketamine guy. I'm not going to say that, hey, everybody, let's just give you ketamine. If I've actually said no to ketamine on a lot of patients because it just didn't make sense.
Okay.
It just was not going to help them. But if we don't have ketamine, then maybe there's something else we can do for you. Neuropathic pain these days, there are options. And I think that we should definitely make those options available to the patients.
For sure. So that's a good point. Dr. Heal, how do you stay in touch with all these different physicians when you all have one patient, right?
Mm-hmm.
And we've got medical oncology, radiation oncology, pain management. Sometimes you've got palliative medicine in the mix. You've got nutrition. How do you all make sure that you're staying on the same page for the patient?
It's definitely a challenge, but most of us have wonderful nurses and MAs that help as well. So communicating between the offices is done constantly. Typically, when I see a patient that's sent to me, so I would say about 2/3 of the patients that I see are new cancer diagnoses, and the other third of them are sent to me because they have symptoms from their cancer that need to be treated. So palliative. So in that case, when someone comes to me, I'm obviously going to be calling the doctor that sent them to me and kind of get a rundown and see what's going on, and then I'll follow up. So usually I just get on the phone. I'm on the phone a lot during the day in between seeing patients, just letting them know what's happening, or we fax our notes to each other. We have electronic medical records that we can communicate with. So it's a constant challenge, but I think for the most part, we're able to talk to each other pretty easily.
That's good. What about you, Dr. Agarwal? Are you spending time between visits talking with other physicians?
well, I think it's a very important part of our job is to communicate well with other patients. Other physicians. So each cancer patient has seen, before they see us, they've already seen different specialists, and cancer is a multidisciplinary approach. Cancer treatment is a multidisciplinary approach to treatment. So yes, on the phone, electronic medical records, we have HIPAA compliant texting, which we use a lot. Charts are faxed between offices. So, and we have regular meetings. We have tumor boards where we sit together and we decide on the plan for the patient, and we give each other updates. So that is communicating with each other as physicians is a very crucial aspect of cancer treatment.
There's just so many of you involved in cancer care. I mean, it's wonderful that there's so many different specialists involved, but it seems like that would be definitely something that's difficult to do, is everybody keeping up with what's going on with the same patient, especially when you see more than one patient a day.
And Dr. Gupta mentioned it, but cancer pain treatment is multimodal. So I might be treating someone's bone pain because radiation works really well on it, but someone else comes to me with a tissue, like a soft tissue tumor. And I think most of us are gonna, what we like about this field, that we do rub shoulders with a lot of other physicians that have different approaches to treatment. And that's where you win the battle, is by kind of attacking it from several different kind of ways.
Yeah, that makes really a lot of sense, because I hear a lot that radiation oncologists are helping people manage pain with lower doses of radiation to the tumor site. So that makes a lot of sense that you all are playing a role there. So you've heard Dr. Gupta talking about all these different ways that he's treating pain. What's going through your minds? Do you guys have patients that you think would benefit from this kind of stuff? Like, I mean, are you already sending? Have you tried them? Tell us what has been your experience with some of these modalities.
So yeah, so we have shared some patients, and patients are very excited about this newer, I would say, form of cancer pain treatment. It does work, and we are happy that we think pain control is one of the most crucial. I can't emphasize more how important it is. Because pain is related to quality of life. If you're in pain, you're not sleeping well, you're not eating well, you're not doing anything, you lose all the excitement. So it's very important for us to do whatever we can. And I'm glad that we have another option that we can use to help our patients. So yeah, so we have used it. It has been successful. And we continue to work closely with Dr. Gupta on treating our patients.
Excellent. Anything to add?
Oh, I think he said it pretty well.
Okay, good. Fair enough. So I just want to take a step back for a moment. We heard about Dr. Gupta and his practice. Dr. Heal, tell us a little bit about your background, radiation oncology, your education, things like that, what your interests are. We'd love to learn a little bit more about you.
Sure. So I think most of us that go into the cancer field, maybe not most, but a lot of people have had personal experiences with either family members and such. And I think that's kind of what probably drew me into the cancer field first. But what really kind of got me into this field is the patients. So, when you're in medical school and you work with a lot of different types of patients, you kind of find what group of patients you enjoy being around and enjoy helping. And I feel like patients going through cancer, such a terrible diagnosis, oftentimes they don't feel like they have a lot of hope. It's pretty rewarding to be able to offer that hope to people and treat their pain and oftentimes cure them. So I'm from the East Valley. I'm here from Arizona. That was where I grew up, and recently joined this group actually this summer. So excited to be back home. But yeah, I love what I do. It's a very rewarding field. And like I said, I would say a good percentage of my patients are new cancer diagnoses that I'm treating with medical oncologists and surgeons and lots of other different doctors. And then a third of them are probably sent to me specifically because they have something that's bothering them and that I have to try and palliate or, either take their pain away or their other symptoms away, like neuropathy or something like that.
Okay, very cool. Thank you. Dr. Agarwal, tell us a little bit about yourself.
Well, the main reason I decided to get into medical oncology because, this is one of the fields which needed a lot of work, especially in India. So when I went into medical school, I was in India, and in India, cancer treatment was pretty much non-existent in the late 1990s or early 2000s. And that's when I thought that this is something where I can make a difference. And then once you develop an interest, you slowly gravitate towards that. I saw more patients with cancer treatment. And then the first time I came to US, I spent a few months at MD Anderson Cancer Center. And I was pleasantly surprised to see so many cancer patients doing so well. So before that, or back home, cancer treatment or cancer diagnosis is considered end of life. But when I was in MD Anderson, I saw so many patients, long-term remissions, cures, and patients doing well. So that really motivated me even more to get into this field. And I'm glad I did, because I think we are in a very rapidly growing field with so many advances. We are improving the quality of care to the patients. We have new drugs which have less side effects. We have better supportive care, better ways to control pain, for example, radiation and ketamine infusion, which are some new additions to our pain control methods. So I'm glad to be in this field at this time, because I think this is history in making. And I enjoy communicating, I enjoy making relationships with the patient, and I think this is a field which is very emotional when you talk to patients and their family, and that's something which I have always enjoyed, and I think it's working out well for me.
Well, it's working out very well for the people of Arizona that you are here. All of you are here. So it's interesting that you bring up MD Anderson, because a lot of times people think that they have to travel for good oncology care. They have to go to a specialty hospital. But we really can provide that level of treatment right here in our own backyard, and people don't have to get on a plane. And having you all here in the Valley is really important. So we're so glad that you're here, and we're glad that you're happy here, for sure.
And if I may just add one
Please.
thing that,
Please.
you know, I have a lot of respect for the AZCCC. I've heard great things about this group, and I've gotten to know many of them. It's really physician-led. I mean, I'm not privy to the financial end of who owns it, but the care is physician-led, and you can tell that. There is nobody on my end either that is, you know, private equity. My wife and I took out a loan on the only home we have to start it, and you know, we really do try to do the best thing for the patient. There's no boss that's saying you must do these many infusions every quarter. There's nobody on their side saying you must refer to Dr. Gupta these many patients every quarter, you won't get your bonus. So whatever we're doing because we really think that's best for the patient.
I love that. That's so important. And I'm so glad that you brought that up because, you know, I am an employee of Arizona Center for Cancer Care, right? And I can second the fact that it is literally a bunch of doctors, just like you, who get to practice medicine for the reasons they got into medicine in the first place, and that is to take good care of patients. And I mean, it's personally for me just so rewarding to know that I get to work with physicians who are doing it for the right reasons. So I'm glad you brought that up. Thank you. Yeah, for sure. Is there anything else you would like to share about pain management specifically in cancer patients before anything you want people to know? I mean, you really did a good job of telling us everything. So,
well, what I would say is that, you know, we live in a world where we try to put patients on assembly lines because we do have a lot of people that need care, and there is a shortage of doctors and nurses. So it seems that if you give personalized care, you're somehow going to burn out. But I do believe that cancer pain treatment has to be very personalized, and that it is very hard to say, well, we can guarantee results because it is a very personalized approach. If you're a young patient, then, you know, sometimes the emotional aspect that Dr. Agarwal spoke about, that can exacerbate pain. Patients suffering from major depression experience pain more. We know that. We know that if you've had surgery as a child, then your response to the same stimulus will be greater than somebody who hasn't had surgery as a child. So we're learning so many new things about pain management and how some of these pain processes are developed in utero, which is to say before they were even born. And so we have to customize treatment. And so that requires energy, that requires time, and we're willing to provide that time and energy.
it's amazing. Thank you. Anything you'd like to share? Last words that you want people to know about radiation oncology and pain management, Dr. Heal?
Sure. I would say if you have cancer or someone you love or knows has cancer and they're in pain, a lot of times I think we live in this silo of our own, what we can do and what we can offer. And sometimes one doctor doesn't have all the answers. And so it's really nice to be in a group like this where we have several different specialties kind of talking about pain management. So if you have pain or someone you know has pain, oftentimes there might be an answer to it. So, my father had cancer when I was younger, and I think back to him now because he was in a lot of pain, and he was just told, that's what happens when you have cancer. There's nothing you can really do about it. And now I see the amount of, the treatments he could have had that would have been very helpful. And I think, I wish he would have asked more. If you're in pain, let your doctor know so they can get you to someone, and we can talk about ways that we might be able to address it. Because there are, I think all of us have said there are new and emerging treatments coming out, and I think it's worth trying so you can have a good quality of life.
That's a great point. Thank you. And Dr. Agarwal, any thoughts that you want to leave us with today?
Well, I just want to say that cancer is a difficult diagnosis, but I do believe to make it easy for the patients, one of my mantra has been that getting diagnosed with cancer is difficult, but getting treatment for cancer should not be. So my goal has always been to personalize, give the most efficient, most up-to-date treatment to my patients. And if you or anybody in your family has been dealing with cancer, talk to your doctor. There's a lot of ways that you can be helped. And there are patients who are diagnosed with cancer and they are cured, but they still suffer from stress related to their cancer diagnosis. There are support groups available. which they need to, if they talk to your physician, or our cancer center has emotional support groups. So there's a lot of help for cancer patients. Don't hesitate to talk to your doctor. Don't hesitate to talk to us. We're here to help, and we'll do anything we can to make it easier for you.
Excellent. Well, thank you all so much for being here today. I really appreciate your time. And thank you for joining us. If you would like more information on Dr. Gupta, you can visit him at www.mountainviewheadacheandspine.com. If you would like information on Dr. Heal or Dr. Agarwal, you can visit them at arizonaccc.com. Thank you so much, and we'll see you next time.